Dr. Kirschenbaum is preoccupied, so we're going to be pinch hitting for him today. I think we've got a lot of great experts here today, whether officially here or just joining us. A lot of people with a lot of experience around knee OA. So wanted to introduce Dr. Brown. He recently published a paper in Journal of Orthopedic Experience Innovation around an evidence-based approach to treatment of knee osteoarthritis. So we'll take a couple minutes, maybe, Dr. Brown, kind of introduce yourselves, tell us a little bit about you, your practice, and kind of what your interests are. And then maybe we'll do a little deeper dive onto the paper and kind of where it came from and your work with the Academy and CPG and things like that.
Okay. Well, thanks everybody for being here tonight. So I am actually currently semi-retired. I practice part-time. I work 1 or 2 weeks a month at Williston, North Dakota. It's a 25-bed critical access hospital. I am employed by the hospital. I have another partner, and we've kind of split it up so we can still both do some subspecialty focus. So I do primarily hip and knee replacements, and he does shoulder and sports medicine. So I'm still active in arthroplasty. My practice is a lot of primary hips and knees and some revision knees. I don't do any revision hips. My background is most of my colleagues. I did a sports medicine fellowship, and they think I lost my way. And I trained with Pete Fowler, and his expression was fake joints. So anybody that knows Pete, he unfortunately passed last November. So a great guy to train with. And so anyway, I did a sports medicine fellowship. I went and spent my first 7 years of my career at a level 1 trauma center, and kind of became the joint guy. I was the shoulder guy, trauma guy, total hip and knee guy. And over my career, I've been associate chief of surgery at Park Nicollet. It was one of the 10 original physician group practice demonstration projects, the Medicare kind of first endeavor into pay for performance, and did a lot of work on quality improvement and outcomes. I was the ortho spine service line lead at CHI in Tacoma, Washington, before I transferred to Williston, North Dakota. In terms of the Academy, I spent about a decade working with the Evidence-Based Quality and Value Committee. It was named some other things, and ultimately that was the name. I was on the committee from 2010 to 2015. There was a gap where I was on the surgical management of osteoarthritis of the knee clinical practice guideline as the American Orthopedic Society for Sports Medicine rep. And then 2016 to 2018, I was the lead sub-chair for EVQV for clinical practice guidelines. And then when I stepped down, I had already volunteered to be oversight chair for the third edition of osteoarthritis of the knee clinical practice guideline, the non-arthroplasty one. And actually, I started as co-chair of the second edition, so heavily involved in the clinical practice guidelines around knee OA with the Academy. So enough of a background, Ben?
Yeah, no, that's great.
I think you clearly are qualified.
Well, some people say those that do, those that can't teach or, do evidence-based medicine maybe. So anyway.
So Greg, tell me, so if everyone's had a chance to read the paper, I'll actually put the link in the chat. So if anyone wants to pull it up, feel free to pull it up. So tell us, you're part of the CPG. I mean, you've got appropriate use criteria. We've got a bunch of, there's a lot of papers on how to manage knee OA and summaries. So why this? Why now? Why you?
The reason I wrote the paper is because clinical practice guidelines can only present what there's level 1 evidence for, essentially. And so you're not allowed to read between the lines. You're not allowed to input a little of your bias, if you will. And so that's what I think that's why I specifically use the word approach, I don't think there's one evidence-based way to manage knee osteoarthritis. I think there's a lot of different ways, and you can interpret the evidence in a lot of different ways too. I guess one of the things that there's a big difference between the second edition and the third edition. And I think the second edition was highly criticized because basically there were only three things that had a strong or medium, moderate strength, and that was NSAIDs, weight loss, and physician or patient education strengthening kind of things. And so the third edition, there's a lot more. If there's any evidence that it helps, we want to give surgeons a lot more options to offer patients. And so there's a lot more things that have limited evidence that are listed as, may consider basically in the third edition of the guideline.
So, looking over your paper, first, you kind of talk about the epidemiology of knee OA and how things are slowly progressing over the years, and imaging and diagnosis. So how do you run your practice? If you've got a new patient that shows up, let's say a 48-year-old, 52-year-old patient comes in with kind of chronic knee pain, what's your diagnostic process?
First thing is I get weight-bearing X-rays and Rosenberg or notch views. I get AP weight-bearing notch or Rosenberg views, lateral and patellofemoral joint. I almost never get a MRI. I think I discussed a little bit in the paper, but I think there's an often misconception that you see full thickness cartilage loss on an MRI and you say, well, that's grade 4, or you see you do an arthroscopy and there's some exposed bone and you say, well, that's grade 4. Well, outer bridge classification is not the same as Kellgren-Lawrence. And so I pretty much do all my diagnosis and grading on weight-bearing X-rays and all my counseling based on that, because I think that's where the evidence is derived from.
Any key questions you ask the patient to kind of understand where they are, the natural history of things?
I guess the biggest question I have, and when I talk to patients, and this gets more as we start talking about surgery, but is how's it affecting your quality of life? What is it you can't do? What is, what's bringing you here? Is it just the pain, or there's certain activities? And I guess the other thing that I may be a little different is that I don't think I can get everybody back to whatever they want to do. And I think that's an expectation of a lot of patients that, you can fix me so I can do whatever I want to do. And I will certainly talk to them about, running and marathoning isn't in your, future anymore. It's just your joints are wearing out. So things like that.
Sean Patel, any questions, any HPI things that really let you hone in on kind of triaging where this patient's going to go in your algorithm?
Yeah, I think, I like to ask them if they had to split up their week into how many bad days they're having and how many good days they're having, and then extrapolate that over the last several months or several years. When that ratio becomes very imbalanced to where they're having frequently more bad days than good days, those are the times that steer me more towards the surgical management as opposed to the conservative care. And usually when that ratio flips, it's very evident to the patient and very evident to us as well.
Right. Mike, Matt, anybody else? Any thoughts?
It's interesting that you talk about the last edition, the new edition of the Academy guidelines, because obviously we all are aware that there were tremendous criticisms of the previous, and we understand you can't put your bias and you can't do so. There's a guy by the name of Bonnaroo who's up at Tufts New England Medical Center who wrote a paper talking about the fact that the criticism of the previous guidelines is they included, and they were using more of a Kellgren-Lawrence score, but in all scores including Kellgren-Lawrence 4. And we know, and if they get a Kellgren-Lawrence floor, they need to go to Matt Barber and get a belt and a new knee and all of that. But the bottom line is how do you respond to that in terms of how we think about our options for arthritis? I think that's a really important question because there's so many people ask about that.
Well, I think that individual in particular has been paid and written by the hyaluronic acid lobby. And so I personally take his criticisms with a grain of salt. I think he's coming at it. Since the 2013 guideline came out, I haven't done a hyaluronic injection since. So I haven't done one for 10 years. And I think, it was certainly the most vocal group with the second edition of that, we recommended not using hyaluronic acid. And that's a big difference with the third guideline. And I think the debate around about is whether it's effective or not. And I think, as I pointed out in my article, I think that's the wrong question. Effective, well, how effective? Well, I think in the third guideline, we had numbers needed to treat of over 20, which means that you have to inject more than 20 patients to find one patient different from placebo. And so if injections, a series of injections is $1,500 and you have to do 20 patients to get one positive result, you're spending $30,000 for one positive result from hyaluronic acid. So is it effective? Well, it's better than placebo, but barely. Actually, one of the things that I thought was very enlightening was a couple years ago, Alex Vaccaro, who was the president or CEO for Rothman, gave a webinar for the Washington State Orthopedic Association, and he commented that Rothman was no longer doing PRP because they didn't think it provided value. And one of the tricks on how to make your product look good is to pick a weak comparator, and there's a nice systematic review. It's like, I think it's 15 or more randomized controlled trials of PRP. Guess what they picked as their comparator? Hyaluronic acid. And it's better than hyaluronic acid, but at least Dr. Vaccaro, as he represented, Rothman isn't using it because even PRP has low value. So anyway, I think that that the individual you mentioned, like I said, has received money and speaking fees from the hyaluronic acid group, and so I take his comments with a grain of salt.
So that's interesting, and I don't know what money's received or not, but I guess my question is, what about the criticism? Because I think this is important as we sort of formulate our opinion of where we go. What about the criticism that the original guidelines included Kellgren-Lawrence 4, which I think we all think just needs knee replacement? If you went to 1, 2, and 3, that the numbers were different.
Actually, again, this is a little bit going down a rabbit hole in the details, but I think it's important to answer your question. And that is with hyaluronic acid in particular, we did multiple sub-analyses and the meta-analyses. We looked at molecular weight, we looked at Kellgren-Lawrence grade. Basically our response to them is like, you show us a subgroup that does, significantly better with hyaluronic acid, and we'll be happy to adopt the recommendation. And they cannot find they can't provide a subgroup that clearly does better. I mean, I think the issue is that there's something called regression to the mean, and I don't know if you're familiar with that, but basically when someone comes in with knee pain, they've got a flare of their knee arthritis. And if you do nothing, they're going to get better. And if you do a hyaluronic acid injection, they do better. Well, so they want to claim that regression to the mean is hyaluronic acid working, and I don't think it is. And so patients come in and say, oh yeah, it really worked last time they gave me a shot. And so the lower your grade on Kellgren-Lawrence, the more likely that this flare of your knee arthritis is going to resolve on its own. So every treatment looks better in lower Kellgren-Lawrence grades. Does that make sense?
So, Greg, let me jump in here. I don't want to turn this into an HA.
No. Yeah, I agree.
What so when patients come in, what are kind of your go-to treatments? You talk about NSAIDs and all that kind of stuff. So, let's say I've got an accountant. I'm just picking just a profession here. Let's say a 52-year-old accountant with KL3.
Yep.
They play, I don't know, flag football or something on the weekend. So, and their knees acting up. So are you telling them exercise, NSAIDs, and weight loss, see you again, and they got a BMI of 42? Can't help you? What's the game plan here?
Well, a little bit of it is that issue. I mean, at a 25-bed critical access hospital, I have no infectious disease. I have no subspecialist. We do have a cardiologist, but we have no cath lab. We can't do it, So there's a lot that we can't manage. So our hard cutoff in terms of BMI is 50.
Not in terms of surgery. KL3.
Oh,
he's got a sore knee. He's playing flag football on the weekends. He's got kids. His knee's sore, and he's having a little more trouble going up and down the stairs. You can tell him lose weight and come back in 3 months.
Well, I mean, I first I tell him is the most effective is NSAIDs, and
Okay.
what's at the
Dr.
end of
Brown, I've been taking a leave for 3 months.
Yep.
When am I allowed to jump in?
What
I'm
are you taking full?
But I want to jump in afterwards.
Oh, I didn't see Kevin. Oh gosh, we're in trouble now.
So is
You
he
are in trouble.
Is he taking 500 twice a day?
Yeah, and I don't want to ruin my stomach. My
Yeah.
PCP tells me my blood pressure's high.
Yeah.
Like
Well,
chicken wings.
so I'm gonna make a little plug. I just got an article accepted and it's in press with Journal of Arthroplasty, and the title of the article is that hip and knee arthritis, not NSAIDs, are linked to cardiac disease.
Okay.
So the link is that hip and knee arthritis decreases activity, sedentary behavior, which leads to cardiac disease. You ask anybody in medicine, how do you get heart disease? And so you'd be a couch potato. And the number one cause of that is hip and knee arthritis.
I get it. But Dr. Brown, I go to work 7 a.m. to 7 p.m. I play flag football on the weekends. I take my kids to and from things. So
yep. So
but
for grade 3, probably my next, if it's absolutely not working, is I'd do a cortisone shot. That would be the next option. Yep. And I think grade 3 is the perfect one to do cortisone shots with. I think there's a nice randomized controlled trial in New England Journal of Medicine that multiple injections accelerate it. So grade 1 to 2, I'm not a big fan of cortisone shots. Grade 4, I think it increases your risk if you're close to thinking about surgery. It increases your risk of infection. So I think the grade 3 patient is perfect for a cortisone shot.
So that way I can get my total knee earlier?
No, I mean, I think I think if you're at grade 3, we're trying to buy time until you get your knee.
Yeah.
And so,
and are you going to do
Come on,
cortisone?
Vin.
Do something
Come on,
like Loretta,
Vin.
which is long
Let me
Kevin,
acting.
I'm going to let you in a minute. I'm going to let you in a minute. Give me a minute.
yeah. So I mean, I'm not sure I understand the question.
Well, so
Yeah, no
the
question.
cortisone. Go ahead, Kevin. I'm sorry, you're
Brown.
driving. I don't want you to
Go
I'm
ahead, Kevin.
helping, Dr. Brown.
Go ahead, Kevin.
Dr. Brown, Gregory, I love you. I love the science. I wrote an article on monovisc and it was no different. And it's a regression to the mean. And I know how to do all that bullshit. But you're right. It's a steroid injection. It's a Zaretta injection because it lasts a year. And it's because in case there's a diabetic and they're all going to have a total knee or they're going to have a uni. I get it. And it's happening. It's in their life because they want to play flag football and they're morons because flag football is for 17-year-olds and that's okay. And it's great. So know that we're going to help the patient and it's a steroid and sports medicine doctors fear that and they want to go PRP. And I wrote the article and all this other monovis and whatever. But the bottom line is it's metal in their future. It's going to be great. And maybe you can catch them early because I will profess that it's going to be a partial, not a total. And they're going to do fabulous and they're never going to get converted to a total knee, but give them the beauty of a steroid injection so they go back to doing everything and they do everything with their kids And yes, I'm not a 2-time, 3-time, 4-time, 5-time steroid guy, but I want them doing things. The My Park Avenue ladies and men, they say, if they don't do it, I'm going somewhere else because I'm going to play flag football, right or wrong. So I think, Vin, it's time to just understand that all that science with PK values out of Stanford and the Marcaine, and it gets rid of the cartilage is crap. Get them back and doing the things they want to do.
Got it. All
Sorry.
right. Thanks for that.
There it
Barber.
is.
Barber, you want to chime in here?
Yeah, I'm just here to try to learn stuff. I think a lot of it, when the rubber hits the road, is what have they tried and then already, and what's valuable to them. Is it time? I mean, there are some people that will spend any amount of money or any amount of time to avoid a shot because they hate needles. I think there are patients that, they don't have or they don't want to invest the time to do therapy or do strengthening. Where does it fit for them? Even kind of to Kevin's point, is it, hey, I need some relief right now and just try to get me back to this for a while, and you try to give them the good talk about BMI and quad strength and everything else that you can.
So, Greg, tell me a little bit more about the rest of your algorithm. So you got a steroid shot. Let's say he comes back in 3 months and says it wears off. What's next?
Are you asking Matt? Okay.
No, Greg.
No. I'm starting to talk to them about surgery and the quality of life, and are they ready to consider surgery?
What surgery? Just so I know.
I stopped doing unis probably 10 years ago.
Let's say they've got global pain, anterior pain, medial pain all over the place. So they're not let's say a uni candidate. Let's just say 42-year-old, 42.
42?
I'll do a total.
Let's say late 40s, early 50s.
Yeah, I'm doing a total.
Really? Okay. What about some of the other stuff in your paper there? Worth trying or not?
I don't think there's much value in most other options.
Okay, let's make it KL2. What happens then?
Well, I'm heavily into the NSAIDs, and I haven't seen many KL2s that don't respond to the NSAIDs, I guess is the issue.
He's right. He's right.
Okay.
They do.
Oh.
But I think,
I mean, the other part, I think the weight's a really delicate issue that we don't talk about enough. I mean, I've struggled with weight my whole life, and I tell patients that, and I say, look, I'm in the same boat, and I'm trying to lose weight, and I'm not real successful at it. So, I at a guy, back to our earlier patient, and he's 42, and we've tried everything, and he's reasonable. He doesn't have any major medical issues. I would do a total knee.
So when you say we try everything, what I've heard is NSAIDs, steroid injection, and now arthroplasty. Is that kind of your algorithm?
NSAIDs, physical therapy or strengthening on their own. Okay. I think exercising on their own and education. I think the other thing that you can't do an evidence-based recommendation on is activity modification. And that goes back to, are you going to stop running or are you going to stop playing flag football? I was a runner, and 3 years ago I had a flare, and I haven't run since. And but I've become a compulsive walker. I mean, I'm doing, last year I averaged 20,000 steps a day. And so I think that activity keeps the joint functioning. And I'm doing NSAIDs and activity and working on weight loss. And I think those are the three pillars of non-operative management for knee arthritis.
Sean, anything else? Looking at Greg's article, he's got a lot of options in there, from radio frequency, denervation therapies. He mentions HA. We've got NSAIDs, Tylenol. What about you? 48-year-old KL 2.5 going on 3.
I agree with what's been said. Similar algorithm: activity modification, weight loss, NSAIDs, cortisone injection. I think the interesting discussion points out of the article are really for the patients that are non-surgical candidates and the role of these alternative therapies like the geniculate embolization and cryotherapies. We've had some discussions with our interventional radiology teams here, and they don't seem very keen on learning how to do it or having it as an option for the non-surgical candidates with KL3 or KL4. I was wondering if anybody else had experience with that, or how their interventional colleagues have responded to interventions like that.
Well, I haven't, but I can tell you anecdotally there are doctors and centers that are very big on what you're saying, Greg, with great results. And so I think it's our fault that we don't open our eyes to listen and see what the other options are when the patient doesn't want, the surgical intervention. But I have to tell you, I know Greg said it was a total knee. I love the article by Mosley. I could kill him, New England Journal of Medicine. There's always a meniscus tear there. Screw that. Right, that you're taking care of the meniscus tear. And there is a role. My mentor, Dr. Stedman, spent his life to people with an arthroscopic intervention. And so it really worked out. And so I'm not, because I'm going to be with Matt. It's ultimately metal. It's happening. It's going to be great. It's going to change their life, but that's fine. And now there are these new pills. I don't know, and I'm not a consultant, that you lose weight, and maybe the FDA is going to approve them for weight loss, because my dad suffered through that, Greg, through his whole life. And I hear you about weight loss, and we know 3 times body weight goes through the knee. So I totally agree with you. But Matt lives in a different world than you do, than I do in Park Avenue. I got to have people eat, and you got to have people stop eating. And so I think it's really exciting. And then if they want to spend money, good. Let's get some cash payer to get something. But go to the steroid, go to the Zeretta, go to the long acting, the diabetics that are heavy. You really can make a difference, I think. And it will last. For me, I know that's black box, 6 months, 1 year. It works. And then maybe do a repeat injection, and then they do it. I love it when I am very upbeat with them and change their psychology.
So we've got
That's
a couple questions in the chat here. So just same thing along the lines of what Kevin's talking about. How the GLP agonists play a role in weight control. Greg, you have any thoughts on that? On a lot of the stuff that's coming out, all the frenzy right now.
Yeah, I mean, I'll plead. I mean, I've heard of it and I've followed it only the littlest bit. I just don't think I don't think we know enough yet. What I will say is, one of the things when I was associate chief of surgery, we were really looking at outcomes, and we looked at bariatric surgery, and we looked at quality of life improvements, and the bariatric surgery patients were seeing 5 MCDs improvement in their quality of life. It's the most amazing treatment. So, I mean, it's big, it's huge to go through. And so, yeah, if you can get the same benefit with medication instead of having to go through surgery, great. But I think bariatric surgery has been shown to have some pretty fantastic outcomes for people that don't eat through their Roux-en-Y or their gastric sleeve.
So we've got another question about iovera and cryoneurolysis. Any thoughts on that, Greg?
Well, I was involved in a paper that we did with the academy staff on the nerve ablation, and that's ablation, which is different than iovera. So I don't have any experience with iovera. I think that basically that the meta-analysis we did for nerve ablation was better than everything. It was better than NSAIDs. It was better than acetaminophen. It was better than corticosteroids. It was better than hyaluronic acid. The one thing that I will say, though, was diclofenac, which I don't think is one of the better NSAIDs. So I don't know, that was a fair comparison. But anyway, I think the ablation is worth trying. But I'm with it like everybody else. I don't have anybody to send them to do that.
Got it. So, I have a conflict with the iovera device. I do have a relationship with Pacira, but we've published a few studies on utilizing iovera and cryoneurolysis, and you can look it up. There's a randomized control trial looking at that specifically for knee OA, and had very good results with using aloe vera for knee OA compared to a sham. So there is some data out there.
How long does it last? That's my question.
Yeah, so patients were followed out to 6 months, and you saw MCID results even out to 6 months in a fair number of patients. The primary outcome was out to 3 months, and so they hit MCID and for I think it was Coos and I forget what the other score was.
Okay, and did they do any repeat treatments? So
no, that was a single treatment. Yeah.
Okay. Yeah.
Single treatment.
Greg, do you have some experiences? So you're a big fan of a steroid injection, and obviously there's been, some criticism about, the ultimate, what is it doing to our chondrocytes and such. But then, we have these long-acting steroids as well, like a Zureta type thing, which is going to be safer in diabetics. It's going to last for a longer period of time. Do you have experience with that up and where you are right now?
I don't have experience with Zureta or any of the long actings. I'm not convinced that it. I mean, I think it's kind of like Exparel. When you compare it against straight bupivacaine, they can't find a difference, and so I'm not sure that the quote unquote long acting cortisones
So, but you're saying you're not convinced, but you have no experience with it. So that
I don't have any.
It's kind of a weird combination of comments.
Well, I think that the way the trials are constructed, they pick a weaker comparator so that they're not doing head to head with the cortisone.
Well, look, we know that one of the placebos they use all the time is saline, and we know injecting saline to the joint is not a placebo, because even just washing out the joint helps some as well. So I think can be a criticism of that, I would suspect, with a lot of different trials.
Absolutely.
I have to make a plug. Greg is a great scientist. I am biased. I just got out of the operating room. My patient's going to be numb for the next 2 days. I just did a knee, and it's Exparel. I'm biased. I say they had Zureta before. They waited. He is, though, 52, Vin. He's not what you said, but he's not 80. And he's ready to go skiing because I'm in Vail, unfortunately, and he wants to do the bumps. And I'm letting him do it and without restriction. So I look forward to more research. I implore, Greg, because you're just outstanding. But I think there is a role for all this, like Michael said, and I don't know that we have the answers yet, but I'm excited to listen to all of you because you're a lot smarter. That's why I love this.
I don't think we're any smarter. I mean, we all have different experiences. I'm coming at this from a very rigorous evidence-based medicine approach, and I don't think that that's very applicable often in clinic, and I get it. I think one of the discussions I had with my hospital president is that medicine has become transactional. They come into clinic, they want something, they expect a treatment. And I'm not sure that some of the treatments we end up providing are really that beneficial, but we just feel like we have to do something. And I have the luxury of being in a small critical access hospital with one orthopedist an hour away and another group 2 hours away, and there aren't a lot of options for them to doctor shop. So I'm not necessarily doing something just to say I did something.
I think that's absolutely the case, and I think part of what evidence-based medicine does is give us a basis for rational discussion with them of here's all these things, here's how likely they may be to work, here's what they may cost you in terms of time, resources, whatever, here's what it may or may not contribute towards your long-term outcome.
I agree completely.
Greg, what do we do? I want to put a health disparities spin on this. I'm in Southern Louisiana. We're usually number 49 or 50. I think Matt may beat us every year or two, every other year.
Mississippi's in there too. Don't leave them out.
And what do I do with patients that aren't resourced to get all the bells and whistles that are potentially out there? So do we just jump to arthroplasty just because? So how do we factor in the fact that if I've got a Medicaid patient, let's say, they're willing to cover HA and willing to cover other things, they don't have access to a gym. Okay, let's be honest, that takes money. They don't, they're fixed, whether they're fixed income and, they can't even afford to buy, a lot of NSAIDs or what have you. So how do we balance what's covered by insurance, what's not covered by insurance? Maybe there's marginal benefit, but there's more risk with some things versus others. So how do we balance all of that to come up with the algorithm that works best?
My protocol is there's nothing in there that's fancy and that isn't covered. I mean, NSAIDs, discussions about weight loss. I mean, obviously getting to bariatric surgery or something but working on weight loss, and I think a lot of weight loss can be done with diet, and sending patients to a nutritionist. But again, they often don't want to do that or can't do that. I think the biggest point in my article is the end. It's the hair transplant guy and I'm a customer kind of thing. I'm treating my patients the same way I treat myself. I take NSAIDs. I stay very active with a lot of walking. All it costs is walking shoes and shorts and a t-shirt. I don't need a gym membership. I don't need anything like that. And if we're getting close to a joint but not quite there, use a couple cortisone shots to get them through towards the end till they're down to grade 4.
Okay. Anyone have any comments on that?
It's so interesting, the emphasis on just straight cortisone injections, because if you look at a lot of the literature and what people are discussing these days, unless you're using a long-acting steroid injection, or unless you're looking for other options, there's a lot of people who I think currently would disagree with you that that's the go-to treatment. And I'm not sure that you're affecting long-term outcome, and I'm not sure that you're not causing some deleterious effect. And it kind of is troubling to me to hear this.
Yeah, I mean, so we published a paper about 5 years ago using administrative claims data looking at steroid injections, and we saw a much higher rate of systemic adverse events in opioid use in steroid patients, believe it or not, compared to HAs and other things. So I think the jury's starting to, really question, are short-acting steroids really as benign and innocuous as kind of we've thought over the last however many decades? We're starting to see a lot of basic science literature, starting to see clinical literature. So I don't know. I think we'll see if that's necessarily.
Yeah, I think that's a very balanced comment. I think that, and I don't mean to be insulting anybody, I feel like I'm listening to 1980s medicine right now.
Well, let me clarify. If I do a cortisone shot a week, that's a lot. Ben's just asking me what's my next step. And like I say, if I've got something that in someone, but I mostly try and talk people out of cortisone shots. I mean, I don't have a big algorithm. Like I said, it's NSAIDs, strengthening activities, weight management, and activity modification.
Yeah, I mean, I think it proves a point. We need a lot more innovation. We need a lot more options. We need, more tools in our toolkit to manage a lot of these arthritic processes. Sean, any other comments?
Wanted to ask you specifically if you've incorporated iovera into your peri-op pain management protocol as a way to decrease opioid use, for instance.
Yeah, so we recently published a paper a few months ago, kind of documenting opioid-free total joint replacements with kind of a more modern multimodal strategy, and cryoneurolysis and some other things are definitely a part of that. So yeah, it's definitely a tool in our toolkit, and it seems to be working well for us. How about any other opportunities here, Greg? We talk about activity modification. Any any tips on, how do we train patients on the appropriate exercise, the appropriate activities? Just tell them, just go start walking. Like is there anything else with that?
Well, I think that for me the tip is not telling them what to do for exercise. Um, so 3 years ago, I trained as a surgeon coach, and part of coaching is you don't give advice, you ask the patients questions. And so what I try and do is ask them, what for type of exercise makes sense for you. An exercise bike, a regular bike, swimming, non-weight bearing activities that they can get strengthening benefit from without putting a lot of load on their joints, non-high impact type of activities. So again, I try and help the patient pick them. Or the other thing I'll do is this is where I'll send them to physical therapy so that they and the therapist can come up with a program that works for them. And then they have some ownership in that program and what's being developed. Trying to advise them what to do, I don't think works. I think they have to own it. And so they have to figure out what it is that they enjoy and can do. I love walking because I listen to audiobooks. I go through over 100 books a year to audiobooks with walking and other activities. And so I just love it because I can go out and get some exercise in, help burn some calories to help me with my weight battle, and enjoy great books. So, but helping the patient find what works for them, I think, is the key there, not advising them what to do.
Got it. And there are some technologies that are out now, like knee KG, for example, where they will analyze the patient's gait and mechanics, and actually recommend an exercise program and different types of braces and things like that. How about knee bracing, knee sleeves, things like that? What do you use that since
Actually, I do like unloader braces. I did my training, as I said, up at University of Western Ontario with Pete Fowler, and part of the reasons I picked that fellowship is they do a lot of high tibial osteotomies, and one of their trials looking at bracing was that was if patients responded well with a brace, they did well. They had a better outcome with high tibial osteotomy. And I actually, when I had a bad knee flare 3 years ago, I bought myself an unloader brace. So it's something not talked about very much anymore, but I think unloader bracing is a value. I think just kind of the knee sleeves off the shelf brace that aren't really unloading. I think there are certain positions where the knee's going to bug you, and those increase proprioception. So I think they have some benefit for the patients. I think if they're bigger hinge braces, I tell patients that I think there's some evidence that actually you start relying on the brace and you actually lose some muscle strength, which is the last thing you want. So I don't, other than an unloader brace, I don't do other hinge braces or things like that.
Okay. We've got a question here about TENS units, using them regularly for pain. Anybody have any experience using TENS units? Now, this is different than NMES, so neuromuscular electrical stimulation, specifically TENS. Anyone have any thoughts on that? No? I don't think TENS have been cleared by the FDA for knee OA and pain management for knee OA. Neuromuscular electrical stimulation, which is different, very different, has. So there's a randomized control trial looking at NMES for knee OA. And so you can potentially, look at muscle stimulation, if you will, from that perspective. And there's some data that shows that can be helpful. Anyone have any other? Go ahead, Greg.
Well, I was just going to say, I think the neuromuscular electrical stimulation is just another form of strengthening exercise, right?
Exactly, right?
So it's consistent with that recommendation already. It's just a different way to do it.
Yeah, 8-minute abs without going to the gym.
Exactly. That's what I was going to say. How to buy a 6-pack abs, just plug it in and turn up the knob.
Yeah, there you go. We've got another question here. Suggestions for patients in an urban population, morbidly obese, poorly controlled diabetes, hypertension. Oh, great. The train wreck, metabolic patient, what do we do with these folks? Urban population, right? So they don't have, miles and miles outdoor to walk. They're dealing with concrete.
Yeah, and I think these are the patients that when I see with grade 2 or 3, that they're not yet ready for a joint, as I really encourage them to go back to their care physician and look at weight management programs, be it a nutritionist, be it bariatric surgery, or now I think the new medication, so that they can start losing weight. So by the time you're ready for surgery, hopefully they've got their BMI down some.
So I'll jump in there too, because I'm same. Bariatric surgery works, which a lot of them won't do. A lot of the new drugs do work well, and a lot of these folks, I mean, depending on the level, they have too much pain to exercise, and diet is honestly is a crappy way to lose weight. I'm sorry, exercise is. I mean, it's going to come down to diet, which is tough for them. Which is where a lot of these gastroparesis drugs come in.
I'll tell you, I've started using peripheral nerve stimulation about over the last year, 18 months. So this is a page out of the spinal cord, out of the pain management spine world, and implanting leads or wires, if you will, deep against the deep geniculates. And then they wear little pulse generator, a little patch thing on the skin. So for this patient, for example, that Cepeda's talking about, morbidly obese, poorly controlled, they're not a surgical candidate. They're not joining the gym anytime soon. They're young, advanced disease. I'm starting to kind of use some of these technologies that we've seen in other specialties and see if we can borrow some of the ideas from others and move them over to orthopedics. Greg, what do you think about your thoughts about arthroplasty in young patients? Going back to that 48-year-old with a BMI of 42, you just gonna, should we buy time? I mean, should we really try to milk this and throw the kitchen sink at this person, even if it's $1,500, or do we do a total knee in a 48-year-old?
I think we do it. I think the most reliable outcome is a total knee. I think the reason I stopped doing unis was when, after the surgical management of osteoarthritis of the knee came out, 7 times higher revision rate. We have one chance to do it right. And everybody says, well, it's easy to convert a uni to a total. And I think that's, from a technical perspective, I think that's absolutely true. But if you look at the New Zealand registry, and there's one other study, and I can't remember where from, what you find though is the patient reported outcomes from converting to a uni to a total has the same outcome as a revision total knee. And so that's why I say you have one chance to do it right. And I think the most reliable way in my hands is a total knee. So I don't have to try and convert a uni to a total and get a
So you wouldn't throw the kitchen sink at a 48-year-old to try to buy as much time as possible. Just jump right to metal and plastic.
Not if it's affecting their quality of life. No.
Okay.
Because I don't think they're effective. I think you're doing them a disservice.
Okay. Matt, do you agree with that? You're like the total joint guru. A lot of people say that you're for compartmental arthritis in a younger patient. At some point they need a conversion. Do you subscribe to that, or do you think everybody goes right to the total knee?
No, I definitely offer uni to some of them, and you just have to have an honest conversation, because that's a mixed bag. I mean, some uni revisions, assuming that they're going to happen over time in that young patient, are almost like a primary. Maybe you got a little medial augment, and I think they do delightfully well. And some of them are disasters, that are as involved or more than some revisions of primary knees.
So evidence-based, right, Vin? So JOA, JBJS, because I have to be where Greg is. I'm sorry, I just went back to the operating room. Unis, 20-year follow-up, 10-year average. You never do the total. It's one and done. If you do it right, hard operation, no debate, love it. And yes, I'm partial to it because Dick Scott taught me how. And you know what? I'm honored that I had the opportunity. Total knee, great operation too. Wouldn't debate it, but shouldn't be done in a lot of people's hands. And that's okay. But I'm ready, and data shows it can be one and done. But that's just my bias. But it's evidence based, so published peer review and been scrutinized.
Well, that's why we got robots, right? So I can't screw up. Anyone? Is there anyone from Max Orthopedics on the call right now? No? Okay. Ira's just texted me and wanted me to thank Max Orthopedics for sponsoring this journal club. So if anyone's there, thank you. So Matt Barber texts or put in the chat, anyone using intra-articular Toradol? Anyone have any experience with that? I use it routinely. Anyone else?
Not I only use it in my periarticular injection intraoperatively. I don't use it in
Okay. So just in my experience, it's good. It works. Not as good as short-acting steroids, but it works without all the worries that I have with steroids. So that's and hopefully we're going to get some
So
evidence.
I'm curious, Matt, what is your with intra-articular Toradol, what's your experience? How are you using it and what's your success?
This is wildly anecdotal and not evidence based at this
I'm
point.
wildly interested.
But it's been early on, and I will say it's been very positive, like Vin's. And a lot of times it's patients, quite frankly. I mean, I've got plenty that just don't want surgery, and 5-6 steroid injections is nothing. I mean, some of them have just been doing this for years and years. And the ones that tell you, well, it doesn't work anymore, but they won't have surgery. What else can you do? Well, I've got this. And so far it seems positive. Again, you're not having to deal with blood glucose issues in diabetics. It's off label and quite frankly, I don't know that we know a lot about it or what the safety of that's like. So I'm doing it in more advanced arthritis, and I'm telling people that it's off label, obviously, but so far been pleased.
So how much are you injecting and how often are you doing it for those of us who have never done
it? 30 milligrams, not more often than every 3 months. And that's unsupported by science, to my knowledge.
Okay.
Yep, that's what I do too.
Okay.
Let's see. We've got another question here. Anyone moving away from corticosteroids and towards orthobiologics? Obviously, insurance coverage is an issue, but is that a go-to for a lot of people? PRP, maybe BMAC, or maybe that's tainted by whether you're sports versus total joints?
So I'll jump in with that. So we've been doing more and more PRP. What we are doing with PRP is we're using 60 cc's of blood. We're doing a double spin. We are ending up with 4 cc's of injection that is estimated to have, and there's been some testing, about 10 billion platelets. I think that there is some I think that it's concentration related, and then that has worked better than the other. And in a small series of patients, they seem to it seems to last longer than the HA that Greg doesn't care for. But I think it's another option. I think it's biology. I don't know that we know exactly 100% we can claim growth factors is working, but the double spin leukocyte poor 10 billion platelet PRP injection has I've had patients like come in just over the moon of how much improved they have been.
Mike, that's just regression to the mean, so I don't know what you're talking about.
Yeah, well, okay. That regression is like a big word, but I'll assume that you're right, Vin.
Okay. Mike, how much are you charging for your PRP?
No, wait. I agree with you completely, Mike. I think the issue is you're very specific about what your PRP is. You double spin it, you make sure you have a higher concentration, and you make sure it's leukocyte poor. And again, The problem is you get all these different randomized controlled trials, and they're all very heterogeneous. But I think the message I came out is that one is that you for arthritis and intra-articular, you want leukocyte poor because it generates leukocyte rich generates an inflammatory reaction, and you don't want that in the joint. But you want the leukocyte rich in the tendinopathies where you try and get an inflammatory reaction for healing. So I think the key you mentioned there, that it's leukocyte poor. I think the other thing is that there's so many different types of PRP that it's really hard to it's hard to say what PRP is.
Yeah.
And so
I think you're spot on. I think the studies are all over the place. And I think that, 10 years from now, we'll realize that we're still just on the very baseline of learning about the biologics. But I can tell you that by doing the double spin, by taking the 60 cc's of blood, by getting that higher platelet concentration, that has been helpful. Now, Vin, in response to your question, and I realize we're practicing in two different environments, and I have been criticized. Well, you're in Fairfield County, Connecticut. People will pay for PRP. There are places, if you go into New York City, and I hope there's no one other than Ira who is on or off, who is charging. We try and minimize the charge. A PRP injection, which is double spin, where the patient's in the office for close to an hour, we charge $1,100. Okay. If you go into New York City, that same injection is probably $5,000. And I want to be able to offer it to patients. You want to be able to cover your costs and your labor and all of that, but you don't want to make it a huge profit center. You want a different and additional option to try and help patients there. And I've got to tell you, it's the enthusiasm has been pretty great. And early on, again, it seems to last longer than anything else we're doing right now.
Michael, are you doing repeat injections at all, series ever, or is it usually one and done?
So it's interesting. So I also take care of a lot of baseball players, Matt. So if I'm doing like a partial tear of the UCL, I am doing a series of 3 injections. That's only a 30 cc. It still is a double spin, but you're probably getting 5 billion platelets instead of 10 billion. And we are doing a series. I've got a bunch of guys with partial UCL tears that are back pitching and playing. For the knee arthritis, it's a different population. We're doing 1 injection with the double spin, and this is anecdotal for anybody who's interested, but if you double spin the PRP, you get about 4 cc's of PRP that is like the absolute concentrate, but then there's about another 10 cc's that's PRP, but not as concentrated. We give that to the patients, they take it home. As it turns out, if you go to a medical clinic or a medical spa, they'll make you a PRP face cream, charge you $1,000 as has a PRP. So we're giving them the other 10 cc's. They're putting it as a facial cream. And I've got to tell you, I saw a woman who was so close to needing to go to Matt Barber for knee replacement, who nothing else worked. The PRP worked great. She's back hiking. She's playing pickleball. She's traveling. She goes, my knee feels great. And she goes, and oh my God, look at my complexion.
That's awesome.
I think the evidence absolutely supports that PRP is better than HA.
Well, I think on our, one of the larger ones I've seen, I think was Cole and the Rush group, and they did a series of 3, and I would have to go back and look and see what the concentration was. You may be obviating that with the double spin, and just it may all strictly be cell number.
I think that Don Buford has talked a lot about that. I think that I'm becoming more and more convinced that the platelet concentration. I know, I apologize, we're getting off subject, but I'm pretty convinced that high concentration. I think he's right with that, and I've seen a big difference in the results.
Right. So we're up against the hour. Greg, any last thoughts before we sign off?
No, I think that last discussion about PRP is critical because it's not just one treatment, and you really need to dig into the details and realize what you're doing with your PRP injection, and not just buy something off the shelf and say this is as good as everything else in the literature.
Right. All right. Well, thanks to Max Orthopedics. Thanks for everybody for sharing some time with us. Hope you have a great evening. Take care.
Hey, Vince, thanks for hosting.
You're welcome. See you guys. Good night.
Right.
Night, guys.